on listen-only mode until our question and answer session. At that time, if you would like to ask a question over the phone, please press star, then 1. Today's conference is being recorded. If you have any objections, you may disconnect at this time. And now I would like to turn the meeting over to Mr. Carl Yonder. Sir, you may begin.
Thank you, and thank you for joining us for the Workforce Grand Rounds webinar series, Combating Healthcare Provider Burnout in Clinical Settings. Today's presentation can be downloaded by clicking on the file located in the bottom right-hand corner of your screen. When the file is highlighted, you can click the Download Files button, then you'll be prompted to save the file in a location of your choice. At the conclusion of all of our presentations today, there will be an opportunity to ask questions over the phone and online. To ask a question over the phone, please make sure that you've dialed in using the phone number and participant code located in the upper left-hand corner of your screen. We ask that if you've dialed in over the phone, please mute your computer speakers as this will avoid an echo. If you are just listening in through the Adobe Connect, you can type in a question in the chat pod, which is located on the left-hand side of your screen. Thank you again for joining us today. We hope that you find this webinar incredibly helpful. I'll now turn the presentation over to our moderator, Education Program Specialist for the Nurse Corps, Juana Rodriguez. Juana?
Thank you, Carl. Good afternoon, and thank you for your participation in this year's Workforce Grand Rounds webinar series. As mentioned, today's topic is combating healthcare provider burnout in clinical settings. The purpose of this is to increase awareness of provider burnout in a clinical setting, including risk factors and preventative measures. This afternoon, you will be hearing from 3 phenomenal speakers. First, Dr. Tori Mack. Dr. Tori Mack is the Deputy Associate Administrator for the Bureau of Health Workforce here at HRSA. She will deliver an introduction and provide an overall federal perspective. Next is Dr. Thomas Ricketts from the University of North Carolina, Chapel Hill. He will speak to burnout rapid response. And then last will be Kevin Hatcher, Senior Project Administrator for Charles Drew University College of Medicine and Sciences, and he will speak to wellness during event-related trauma. So without further ado, I would like to introduce Dr. Tori Mack, Deputy Associate Administrator for the Bureau of Health Workforce.
Thank you, Juana. Hi, everyone. Thank you so much, and good afternoon. I've been looking at the chat box, and it's just great to see everybody from all across the country. Thank you for putting in where you're from. I've appreciated reading that. So again, I'm Dr. Tori Mack. I'm Deputy Associate Administrator for BHW. Our mission is to improve the health of underserved and vulnerable by strengthening the health workforce and connecting them in need. You know, Workforce Grand Rounds is just one way in which we support the strengthening of the health workforce. We host experts and thought leaders to share evidence-based practices. I'm really excited about the official return of our Workforce Grand Rounds. The topic of clinician burnout that we're going to talk about today was selected by feedback we received from you, as well as from previous Grand Rounds. It's really especially important, and especially in these new and trying times. So today, I'm going to discuss provider burnout in a clinical setting. First, I want to discuss the impact of COVID-19 and what that's having on the workforce. I want to talk about clinician burnout more broadly and why there are high stakes for inaction. And I also want to recognize those risk factors, particularly for newer providers to avoid burnout, identify preventive measures, as well as resources to promote provider well-being. Next slide, please. So COVID-19 and its stress on providers. So, you know, it's very early in this pandemic to have significant studies of the emotional and psychological toll of fighting COVID-19, but we do have early reports that we can look to, as well as findings from SARS and MERS outbreaks and other disasters that really confirm this heavy burden on our caregivers. This is just some of the stressors, and these would include the prolonged uncertainty, just not really knowing what the ultimate magnitude is going to be. It's changing day by day, the duration. What are the long-term effects? There's new studies with new effects that are coming out, particularly in the pediatric population. Concerns about the level of preparedness within, you know, your own personal life, within your healthcare organization, in the public sector in general. Providers are also stressed with the lack of needed supplies, as a perceived lack, whether it be the personal protective equipment or other needed supplies, equipment and tests. And then potential threats, you know, threats to their own health, especially if they themselves have pre-existing conditions, stress to their loved ones or their coworkers if they also may be at risk of exposing to the pandemic. Next slide, please. As a result of these stressors, a considerable portion of healthcare workers have reported experiencing these acute sort of psychological symptoms that would include depression, irritability, anxiety, insomnia has been reported, as well as just overall distress. These are particularly prevalent among women, nurses, particularly those in Wuhan, where we get a lot of this research from, as well as frontline healthcare providers, those who are directly involved with the diagnosis, the treatment, those who are providing nursing care as well, in terms of to those who are suspected or confirmed with COVID. I just want to point out that these effects are additive, right? So these are piling on top of a workforce that's already facing impacts of burnout. And so you can think about COVID as really being acute stress on a chronic problem. Let's talk a bit about that chronic problem on our next slide. So starting out, what is burnout? So there are a few different definitions, but they really hinge on the same three areas. And so as I go through these, I'll talk about some of those other definitions as well. This one in particular is from the World Health Organization. I want to point out that this is chronic workplace stress that has not been successfully managed. So the three dimensions that we look at when we talk about burnout are exhaustion. So that's that feeling of energy depletion, or really that emotional exhaustion. Next is that cynicism. Another word for this could be depersonalization, that increased mental distance from one's job, or feeling of negativism or cynicism related to one's job. The next is inefficacy, and particularly this is reduced professional efficacy, just a low sense of personal accomplishment, that you're not achieving what you thought you would be. And again, I want to highlight that burnout is an occupational phenomenon. Of course, it can impact the workforce and their loved ones outside of the clinical setting, but its roots lie within that setting, and so the solutions should as well. Next slide, please. So just looking at the causes of burnout. And these were taken from a recent publication called Taking Action Against Clinician Burnout from the National Academies. It was from October 2019. Just looking at the factors that contribute here. Those are job demands and, the imbalance between those and job resources. Job demands can include workload and time pressure, various intrinsic aspects of clinical work, like moral distress, having to act, contrary to one's own values, work inefficiencies such as administrative tasks, or technology or trouble with the usability, workflow hiccups, and interruptions. Key to this is that you'll see at the bottom among medical students and residents in training, burnout is more associated with that, suboptimal clinical experiences. So think about that when we talk about our training opportunities, inadequate support when they are in training, whether supervisor or peer behaviors can also have an impact, maybe that lack of autonomy, and then the grading scheme that can also serve as a stressor for them. Medical students and residents in training experience burnout that may carry over into practice and can actually see an increase in incidence as they move along. Next slide, please. So what is the scope of the problem? Even before the extremely unique challenges of COVID-19, caring for providers has been a challenge for many systems. On average, about 50% of physicians, nurses, medical students, and residents as well are experiencing symptoms of burnout. And actually, medical students and residents, that number is often higher. Physicians are experiencing burnout at twice the rate of other American workers. And one key point is that burnout is not unique to healthcare, but what we've seen in the preceding years is that while the rates have remained pretty stable for other U.S. workers, they've actually increased among physicians and healthcare workers by as much as 9%. And then our frontline providers, those caring for our sickest, whether it be in the emergency room and family medicine and general internal medicine, are experiencing the highest rates of burnout. Next slide, please. Again, a little bit more about the impact of burnout on the healthcare system this time. And so how does this impact the system? How does it impact care? So physicians specifically for this slide, who are burnt out are twice as likely to be involved in patient safety incidents. They're twice as likely to deliver suboptimal care to patients due to low professionalism as one cause. And they're actually 3 times as likely to receive low satisfaction ratings from patients, which we know patient satisfaction is very, very important in terms of the quality aims for healthcare. And while the economic impact of burnout is challenging to calculate, what we have listed on this slide is really a conservative estimate, $4.6 billion from the Annals of Internal Medicine, but the ranges can go up as high as I've seen at $6.3 billion. So the costs are high, and some of the attribution to this cost would be increased absenteeism for providers, reduced productivity, increased medical errors and safety lapses, and more malpractice claims, just to name a few. Next slide, please. When we look at the impact of turnover, so the last slide I talked about sort of the economics, but additional economic costs can be incurred by turnover, which is just the cost to replace these healthcare providers that we're losing. So this is from some cross-sectional studies on physicians specifically again, and it's really talking about the job dissatisfaction and how that led to intent to leave. They're 3 times more likely to have intent to leave for reasons other than retirement when they're found to have burnout. Again, when we talk about replacing, the number in the figure in the middle is talking about the cost of turnover for RNs specifically. And that's estimated to be 1.2 to 1.3 times their salary to replace them. And of course, looking at diagnosis physicians and healthcare providers, the range is going to be pretty significant depending on specialty, location, the length of the vacancy, and other estimated costs. But around $500,000 to replace a physician, but of course some specific specialties can range up to $1 million. So again, just showing that there's high cost for provider burnout. Next slide, please. I want to talk about some good news. So there is good news. There are some protective elements. There are some tangible and intangible resources that can counter burnout, and I want to talk about those in the next few slides. Some of these are really having that meaning and purpose in work that goes back to that inefficacy, right? So trying to combat that preemptively. Having positive work and learning environments. Really having alignment with the values and expectations of the organization. Having some job control, flexibility, and autonomy, protective as well. And reducing those administrative burdens, whether that be through optimized workflows and technology. That's another example of a system improvement that can be made at that level. Interdisciplinary team collaboration has been found to be protective as well, and really having a supportive and effective leadership. On the next slide, I'm going to get into these a bit more. So strategies to reduce. So how do we take those preventive measures and really make those into some systemic solutions that we can use? So again, I want to point out that burnout is a system issue. So counteracting burnout cannot rest solely in the hands of providers. Early on, a lot of organizations took that approach, specifically offering, whether it just be some wellness opportunities for providers, which is important. But in the characteristics of personality, of course, the outlook of the provider can certainly factor in, but counteracting burnout cannot rest solely in the hands of those providers. So what can organizations do to reduce clinician burnout and promote this engagement? This actually comes from, this slide is from 2017 article in Mayo Clinic Proceedings. It's Dr. Tate Chanafelt. And really these are some clear focus actions. Let's go through them. First, acknowledging and assessing the problem. So assessing regularly. Everyone knows that organizations that measure, they measure what they value, right, and what they think is critical to success. It's really important to have that assessment to really have a tailored approach. Next, harnessing the power of leadership. So selecting the right leaders, often that could be diversity in leadership. Having chief wellness officers is something that, or a wellness champion is something that some organizations are using, really showing that they are really taking a focus on wellness. And then equipping the leaders to be successful as well. Next, developing and implementing targeted work unit interventions. And so again, going back to those targeted interventions after you assess the problem. Of course, many of these issues are generalizable, which is what I was talking about earlier, but the manifestations vary widely, and so should the approaches. Next, cultivating a community at work. So connection with colleagues, nurturing peer support, whether it be formal or informal, are ways in which you can cultivate a community at work. The next action would be using rewards and incentives wisely, just willing to be intentional in awarding those values that you have as an organization. And the next, aligning values and strengthening the culture. So having shared goals and values, involving staff in what those goals and values are and how to collectively work towards that common goal. Promoting flexibility and work-life integration. Of course, the first thing people would think about is, can we reduce hours? But really just thinking about what you all want to accomplish and what the barriers are to overcome those. Talking about that as part of the team and having a team help with those solutions. And then again, providing resources to promote resilience and self-care. This is best received, as I was stating, as part of an overall strategy. You don't want to send the message that it's an individual problem, but really as part of an overall strategy, it can certainly be effective. And then facilitating and funding organizational science. So adding to the evidence base. This is something that can certainly bring to the group a sense of meaning and hope. Next slide, please. So now I want to transition and talk a bit more about HRSA's efforts to address burnout and how we've implemented some strategies. Next slide, please. And so on this slide, you can see we have the quadruple aim, which added to the triple aim, which was really looking at how we can have quality in healthcare, improving patient experience, enriching population health, and reducing costs, and then the quadruple aim as enhancing provider well-being. And what you see here is from our Advisory Committee on Interdisciplinary Community-Based Linkages. It's one of our advisory committees that we serve as the designated federal official for in BHW. And in one of their recent recommendations from 2019, they recommended that HRSA work across divisions and programs to include specific language in our notices of funding opportunities to develop evidence-based practice models that prevent burnout, foster individual team well-being, resilience, and attention to advance this quadruple aim. Next slide, please. In large part, as I was stating earlier, we're looking at an imbalance of job demands and job resources. And under the direct influence of healthcare organizations is what we've been looking at and thinking about where clinicians work and train. So in BHW, the Bureau of Health Workforce, we are continuously looking at ways in which we can support provider wellness, whether it's during the education phase, the training phase, as well as the clinical phase in terms of service to rural and underserved communities. And so toward that end, what you'll see here is some ways that we are incorporating provider support into our programs. We use a number of strategies. They range from the fostering well-being, as I was talking about, but also counteracting the factors that contribute to burnout, ranging from self-care efforts to enhancing support of our providers through stronger relationships with peers, colleagues, mentors. We do pre- and post-program assessments to really help us gauge the result of our efforts. I'm going to talk about one particular program on the next slide. So I want to talk a little bit about our primary care training and enhancement program as a provider wellness example. PCTE is the acronym for Primary Care Training Enhancement. Its aim of the program is to strengthen the primary care workforce by supporting enhanced training for future primary care clinicians, educators, and researchers, as well as promoting primary care practice in rural and underserved areas. The grant program seeks to produce primary care providers who are well prepared to practice, but then also to think about quality of care and cost effectiveness as well. So this program takes a systematic approach to improving trainee, provider, and faculty wellness. And so specifically, I'm going to give you a few examples. And so University of South Alabama, for example, uses instructional materials and interprofessional care delivery, patient engagement, and self-management. We have Northeast Ohio Medical University. In their professional foundations course, medical students develop and implement self-care plans with 10 hours of course time to actually implement those plans. And then in my final example, Emory University has an intern wellness retreat that's at the end of their first year of training that specifically examines issues of burnout, identifying the signs, teaching resilience, and giving trainees tools to be better equipped for those difficulties that will arise in the profession. Next slide, please. HRSA is also taking steps to help by, among other things, studying what factors affect provider well-being and which ones rise to the top, particularly among our health center workforce. Our Bureau of Primary Health Care recently launched an initiative to study that question. And so, as you can see, Phase 1 and Phase 2 is where we are looking for in the future. And so what we really think is that in a few years we'll get some results, and we don't quite have them yet, but I suspect they'll be quite enlightening. Next slide, please. Additionally, in the Bureau of Health Workforce, we have cooperative agreements with health workforce research centers across the country. We have the University of Michigan, which is looking specifically at the impact of COVID-19, as I was speaking about. We have the University of North Carolina at Chapel Hill, which has a program on health workforce research and policy that's looking at quite a few efforts, including developing a better understanding, and particularly understanding some factors along our ends. As I mentioned, they have significant impact of burnout, especially in light of COVID-19 as well. Next slide, please. We have George Washington University Health Workforce Research Center on policy, which is looking at ways in which we can improve those administrative practices, such as medical scribes, and how that might have an impact on clinician burnout. We have UC San Francisco, which is looking at that long-term care support services, looking specifically at home health and staff turnover. We have the University of Washington, which is looking at our allied health workforce and whether there are wage consequences of illness and burnout in terms of allied health workforce. We also have the University of Washington, which is looking at health equity, really looking at that resilience. What are those keys to that and burnout and the potential burden of being underrepresented in health profession programs and how that would relate also to burnout? Really important question. Next slide, please. And then about a year ago, and these resources are available on the website links. A year ago, HRSA issued a special edition of the Primary Healthcare Digest. It was focused on the issue specifically of workforce engagement and well-being. This is really rich with resources of all types. These two issues in particular can help you launch a wellness program. You can find material to expand a program that you already have. And I just want to point out that the digest regularly features a workforce section, including some resources and training opportunities, so I encourage you all to please take a look. Again, just healthy and engaged health center workforce is one of HRSA's highest priorities as well. Next slide, please. So improving healthcare. So I really just want to close with a quote that was from the Mayo Clinic proceedings that I talked about a bit earlier. Any healthcare organization that recognized it had a system issue that threatened quality of care, eroded patient satisfaction, and limited access to care would rapidly mobilize organizational resources to address that problem. Burnout is precisely such an issue. And even more so now, in light of the pandemic, there are high stakes for inaction, but again, there are targeted interventions that can help in almost every setting and program. And it's just really an issue we all need to embrace to recruit and retain staff and to build a healthier population. So thank you all, and I would now like to turn it back over to Ms. Juana Rodriguez. Thank you.
Hello, okay, thank you so much. I was on mute, so I was talking. Next, I would like to go ahead and introduce Dr. Ricketts. Dr. Ricketts, the platform is yours.
Okay, thank you. Coming up from our first slide. Okay, yeah, I'm Thomas Ricketts at one of the workforce centers that Dr. Mack mentioned. I'd like to thank the National Center for Health Workforce Analysis for supporting this work that we've done through this Workforce Centers program. Doctors Michelle Washko, Dr. Robin Streeter have been very helpful and supportive of our work, and it made us feel an important part of the HRSA family. The impetus for this rapid response, and this is a rapid response request, meaning try and summarize everything that is known about an issue very quickly. originated in HRSA, and Dr. Mack was really the primary force behind that. Because of its increase in importance both across the system, as well as a system that is now being stressed by the COVID pandemic. So our rapid response made a lot of points that have been Dr. Mack has covered, and in fact there'll be a lot of overlap here. But I wanted to make some observations about burnout from an external point of view. Next slide, or here we go. Burnout. We know a lot about burnout, and Dr. Mack's presentation really emphasized that there are multiple lines of research and multiple lines of, let's say, intervention that have really been able to reduce or show promise of efficacy in burnout. Now, there is a generalized definition, slightly different from Dr. Mack's. This is from the National Academies, and I do recommend the National Academies' work on this issue, their recent work, as being authoritative and useful. But it's seen as a complex multifactorial problem facing healthcare professionals that includes indications of depression, lower productivity, reduced professional work effort, and an increased likelihood of leaving practice. So we have a fairly concise definition. One of the things that is not accompanied by this is or that doesn't accompany this is a diagnosis. Burnout is not a psychological disorder or been recognized in the DSM as that, but it is a well-recognized organizational and personal phenomenon. Another thing we can do is we can measure burnout. A lot of work has been put into developing measurement systems and metrics. And since burnout was identified and given its name by Christina Maslach and Susan Jackson, when they published their first version of a burnout inventory in 1981. Dr. Maslach is credited with originating this term burnout, drawing on the title of a Graham Greene novel that describes a professional, an architect in this case, as its main character. And he runs away to a leper colony in Africa and is diagnosed by the local physician, a French character, as or a Frenchman in the novel, as a burnt-out case. In the Maslach scale, which is there are 5 different versions. There are many different versions of indices of burnout. The Copenhagen Index is used primarily outside the United States in English-speaking context, and the National Health Service in Britain uses it quite often. There's also a simplified, ultimately simplified version down to a single index created by Emily Dolan. And so these all have apparent and validity and credibility. So we do understand that we can measure this, and both as a predictive and a diagnostic tool. So I'm going to describe more about burnout in a moment, but I want to point out that I'm not a person who's done original research in this field. I'm trying to present a journalistic picture of the issue to summarize what is known and provide some interpretations of that body of knowledge and suggest some directions for policy. I have, however, studied healthcare practitioners for quite some time. One of my earliest projects was following up on a group of 60 generalist physicians who entered practice in North Carolina in 1950 and 52. And I interviewed them in 1977 and 78, asking about careers and satisfaction with their profession. Burnout was not a thing at the time, but more than half of those physicians had dramatic changes in their practice, but very few had actually left medicine, which was quite interesting. I've studied other health professions in rural primary care practices in our national evaluation, but we call it professional satisfaction or dissatisfaction at the time. And we measured that in the context of practice efficiency and impact, and found that physician satisfaction was extremely important in the overall quality of care, as well as the efficiency with which the clinics and centers were run. Both of these initial studies were influenced by my work in a minority recruitment program here at the University of North Carolina, and later work on what was called the physician work-life study, and later research looking at the life course of healthcare practitioners, ranging from frontline workers to subspecialist surgeons. All of that work still continues in our center, but I want to emphasize that the view of burnout that I give is in the context of training, practice, organizational influences, and life course across a broad range of professions, occupations, and their combinations. Many organizations, well, let me continue by saying that, as I've said I've looked at burnout a lot, and the really important things that I've found is that we really have an organizational structural problem in contributing to burnout. The increasing bureaucratization and imposition of formal organizational structure in almost all facets of healthcare. And this is part of the rationalization of healthcare as it is organized more and more into systems governed by bureaucracies. And that in turn has an effect on the self-efficacy of practitioners and other workers. Information systems are very important in their pressure on healthcare practitioners and workers. This is information technology, to many you recognize, has been perceived as adding greater burden instead of improving efficiency in programs. There's a pressure on the training system as the volume of knowledge expands and the array of skills that are necessary to qualify into professions expands. And this is pressurizing students in preparation, but also in continuing education. And then there's the addition of complex technologies that require adaptation to demands of machines and automation and caregiving. If I was to point to the two salient factors that are mentioned, most often it is the problem of electronic medical records, and now COVID-19 and the pandemic. This creates its own structure of threats and pressures, including moral dilemmas or an increase in the moral dilemmas facing the practitioner. And this is closely followed by the pressures of information technology that have come along with that. COVID-19 is a pandemic that is being faced in the context of information technology, and whether it can support our better understanding or whether it stands as a barrier is an open question. Many organizations are committed to reducing burnout, and these organizations and institutions that represent practitioners are really engaged in supporting efforts to reduce or prevent burnout. Professional and occupational associations have led in this effort, but government agencies at the national and state level, including HHS and other federal agencies and state organizations, especially AHECS, have recognized the challenge of burnout along with supporting policy entities, two of which I'll mention because of their recent and comprehensive work on this problem: the National Academies of Science, Engineering, and Medicine, and the Institute for Healthcare Quality Improvement. Their publications and programs on this are comprehensive and provide guidance for others seeking to reduce burnout or cope with it. I must mention that HRSA has paid very close attention to these documents. You just heard that in Dr. Mack's presentation. And they also are independently developing practical programs and supported efforts to reduce burnout, and have done so for multiple years, even before it was named burnout in the late 70s. I know that as we worked with them in the evaluation of primary care programs, they were very concerned with provider retention and provider satisfaction. In identifying and developing metrics of burnout has been something that has developed more recently than just defining the problem. And it's only now that we're getting a handle on the costs and impacts of burnout on the system and healthcare outcomes. Those estimates, cost estimates, come from work that was done only in the last year or reported in the last year. We do know that burnout is common among health professions, specialties, and occupations, and it ranges in prevalence from 30% to 60% across those professions and occupations. We also have noted that burnout, since the time of its formal description until today, has seemed to be on the increase. That is, from the 1980s until now, there has been a general increasing trend, but there is some indication that this is leveling off, at least as it is now measured. This plateau in burnout incidence, if not its prevalence, is attributed to the fact that the current entrants into healthcare professions and occupations are becoming more accepting of the technological and organizational realities of healthcare delivery and the careers in their field that depend upon those. It makes them somewhat expecting of these pressures as opposed to having to adapt to them. These new entrants may be more skilled with information systems and more used to working with screens and data entry than their predecessors, although that's a broad generalization. And their options and futures are more often limited to large bureaucracies than any form of independent or self-directed work. These are, however, hypotheses about this transition into the worker of the 21st century, the healthcare worker and professional of the 21st century. Now, as I said, investigators only recently begun to estimate the costs and burdens of burnout. This first effort in 2019 estimated up to $4 billion in the cost, but that's a very, very rough estimate and has a range around that if you look into the work by Drs. Han and Shanafelt and others. A formal definition to guide the accounting of burnout has yet to be developed. Really, we understand grossly what the impacts might be, I emphasize that, but we really don't have a detailed system of looking at where the costs are in specific parts, although we have a pretty good idea and a pretty good grasp. The National Academies, as Dr. Mack pointed out, has developed broad scope categories to which to measure burnout effects. And those are the safety and patient outcomes, effects on clinician health and well-being, and turnover and reduction of work effort. We have a pretty good handle on the last one, turnover and reduction of work effort, because it's based upon existing knowledge in other fields, as well as prior work specific to that. But the safety and patient outcomes is the place where we really don't have as much information as we need to have, and we should do more research on that as it is tied to the problem of burnout or stress on healthcare workers. In terms of an impact to HRSA, I did some back-of-the-envelope extrapolation and estimated that the cost to the National Health Service Corps, for example, would be upwards of $17 million just in recruitment and expenditures in a 2-year cycle. It might be that the Bureau of Primary Health Care faces a cost of up to $101 million due to dropouts, reduced productivity, errors, failed recruitment efforts, and even the cost of lawsuits from those errors. I would like to note that pressure to estimate the cost of burnout are likely being driven by one of the characteristics driving burnout itself, the increasing bureaucratization of healthcare. As healthcare becomes more structured and organized into systems and complex organizational expressions, there is going to be a greater need for accountability within those systems, and part of the accountability is going to be the ability of practitioners to contribute, and whether that there is pressure that causes them to reduce their value, their adding value into the system. As I mentioned, HRSA has taken on burnout as an important challenge. I quote Dr. Parham Hobson describing it in the context of quality of care, and Dr. Mack echoed that about moving from the triple aim to the quadruple aim. The quadruple aim adds an element of practitioner satisfaction and practitioner self-efficacy to the old triple aim that was to produce a value-based system. Now, that's kind of thing that is being discussed in HRSA. This is not the first grand rounds. There was one in April of 2018 to give you a sense that they have been working on this for quite some time. I do think HRSA is in an excellent position to work on the burnout problem because they are both the sponsor of functioning healthcare delivery programs, but also a very important supporter of the pipeline for training healthcare professionals. I'm going to argue that an equally important challenge to reducing burnout is its prevention in the pipeline, as well as its reduction in practice. To support that contention, I'm going to point to the recommendations made by the Advisory Committee on Primary Care Medicine and Dentistry, and those were reflected in the other advisory committee that Dr. Mack presented. But they had 4 points that that breaks us down a little bit more. And they'd have to do with emphasizing preparing new practitioners for the realities of the healthcare system, investing in mitigation strategies when they are engaged in the system, and research into newer and more effective strategies. If we're to improve care, we need to constantly look at what we're doing, understand the best mechanisms, and change in a continuous process of improvement. And then one thing that is a challenge sometimes to HRSA is that this type of effort needs to be integrated across its multiple programs and initiatives that the agency supports. Any assessment of the problem of burnout in HRSA programs ought to start.
I need about 15 minutes.
Yeah.
I said, don't back there for about 15 minutes. I got a phone call.
Okay. Any assessment of the problem of burnout in HRSA programs really ought to start with an overall conceptualization of the logic of the programs and how that would fit into what I call the policy space for the agency and its work. This is how I describe a policy space of looking at things to see how much you can change them and how you can change them and what their effects are over time. I think that this type of conceptualization, and this is just a draft type of work, but it's the kind of thing that guides me when I try and develop evaluations, is that there are places where we can probably get more, say, bang for the buck, and those are really down in the lower left-hand part, early on, where we're dealing with the selection of people, where we're identifying those people who might go into future careers, and then we're influencing their lives with the giving them ability for training specific to resistance, as well as showing them role models who are able to cope and survive and thrive in the healthcare delivery system. This type of evaluation structure is speculative and untested, but I think there are, if we discuss these things, we can begin to find out some things where we might want to invest more effort than in others. One approach to understanding and changing occupational satisfaction and conversely reducing burnout that has proven itself in really mostly in other fields is the life course approach. I've learned a lot more about this from my work with the North Carolina Workforce Center Director, Aaron Freyer, and our colleagues at UNC who use this in much of their work. Life course theory concentrates on the transitions in any person's work life along their trajectory, their occupation, their lives, as it were. And across that trajectory, they have transitions and turning points that occur both early and late in the course of their work life. These occur in the context importantly occur in the context of race, gender, place, age, and identity. And I can't emphasize these forces anymore. I mean, I can't really, these are the important elements that you have to really put into the context of people's experience, because life's experience is conditioned by these characteristics of individuals in organizations and in life. And it is these things which modify or prevent or amplify their ability to make transitions, and when they can make the transition, and the type of transitions they do make. And we have to recognize those special conditions. And recent discussions in the real world, I think, make that really obvious. But there's also this question of whether burnout is something that builds up in people or something that can be modulated as it goes up and down. There might be people going to a breaking point, building it toward a breaking point, and there might be a situation where you can reduce and remove those factors and let people move along. But these are all done in the very many contexts. One of those contexts, obviously, is the COVID pandemic. Lately, I've seen some of these signs around in various neighborhoods, and they suggest something to me that I think is not necessarily ideal. They suggest that healthcare workers are warriors of a new sort, and that their warrior characteristics help them continue to work in the face of the COVID pandemic. This is, I think, useful only in the shortest term, that it may actually create problems for healthcare workers and professionals as they seek to enter and continue careers. The warrior mentality, and I come from a military family, but was not in the military myself. The warrior mentality and the support of warriors in the military are relatively well understood. One time it was called esprit de corps. And it is the strongest bond for the strongest bond for warriors, and the single greatest motivation is to not let the team down. Don't give up on your brother next to you or your sister. You must stick with the team and do what's best for them, and don't give up. Warriors also face intense but transient episodes of deadly pressure and mortal, even existential threats. Then that threat is eliminated as they rotate away from battle zones. And that is one of the primary strategies in war, is that you move people in and out and away, into and away from danger. This does not apply to healthcare professionals as workers who have to maintain day in and day out a high level of performance in the face of threats, who have to come home to families or homes on a daily basis and care not just for their team, but for their families. And the professional role emphasizes an individualist deontology, an individualist obligation. So far, the bureaucracies in the organization, and I'm not trying to be flippant here, but they've really not taken on the burden of errors, individuals' errors and practitioners' failings, but are just now beginning to see this. But it is still the individual who is facing this constant pressure. And in the world of COVID, that pressure is unremitting and not exactly like being a warrior in battle. This life course approach that I'm suggesting might imply that we look at satisfaction in the long run, that we look back at careers to see what could be changed that would reduce stress and burnout. I'm not sure that would give us real actionable guidance. If we do ask people what they would change, it is often that they'd work less. If they wanted to tip the work-life balance more toward the latter, that is, toward life rather than work. But that would run counter to our efforts to actually increase productivity engagement for healthcare professionals and workers. While this may not seem an obvious conundrum, I believe it does present us with a challenge to not only motivate people to work more effectively, but also to enjoy their lives as well outside of their work. So there's an internal illogic here, but we probably want to spend more time dealing with the positives that promotes people's resilience rather than dealing with a problem after it begins. So in the end, at least at the end of this session, I'm suggesting we promote the more positive elements of healthcare work life as much as we seek to reduce the negative. We seek things that prevent burnout from occurring as much as or more than those things that treat it. We want to give people a sense that their lives is part of their work, as their work is part of their lives. As in healthcare in general, prevention is likely the most effective approach for reducing burnout in the long run and reducing these costs that we'll soon be estimating more accurately. So thank you. I appreciate the time.
Greetings all. My name is Kevin Hatcher, and I am the Senior Project Administrator for the at Charles R. Drew University for the Primary Care Training and Enhancement Project. Today I'm going to be talking to you about how to increase, the purpose of the conversation today is to increase awareness of provider burnout in a clinical setting, including risk factors and preventive measures. I'm going to talk to you about a pilot study that our principal investigator, Dr. Lisa Barkley, who's among the on the call, that she performed. I'm also going to talk to you about, describe a little more about our project, and then introduce some key strategies for early intervention and resources for those that are experiencing burnout. So Charles R. Drew University was founded following the Watts Rebellion of 1965 to address the healthcare shortages and hospital shortages in South Los Angeles. We are a minority-serving institution and a historically Black graduate institution, also a founding member of the Hispanic-serving health profession schools. Dr. Charles R. Drew is a pioneering African-American physician who overcame racism in the mid-20th century and went on to produce seminal work on blood banking, plasma storage, and transfusion. And our mission is to cultivate diverse health professional leaders dedicated to social justice and health equity for underserved populations. So what we learned from Charles R. Drew is how to flourish. You know, it was more than just surviving, but how to flourish through these event-related traumas. What you see pictured here is a recent demonstration from our faculty and our trainees. They, we listened to them, and they required protected time to be able to express themselves about the police murders taking place across our country. What's important to note here is that for our providers, there's a specific type of burnout, stress, and exhaustion. You know, it comes from a lot of different layers, you know, and as you see pictured here, they're also in PPE, because they are, we are dealing with the COVID-19. And so one of the other things that I wanted to point out is that because we care for low-income patients of color who are impacted by health disparities due to social inequities, we experience vicarious traumas from these experiences. And so, you know, any plan to address burnout or wellness has to take those into consideration. So our project director and principal investigator, Dr. Lisa Barkley, conducted a pilot study, more of a qualitative inquiry, but she wanted to know if healthcare providers of color, do they experience discrimination in the workplace, and does that increase burnout and impact their career choices? What she found is that residents and attending physicians of color have experiences of burnout and frequently face discrimination in the workplace. These experiences influence their career choices, such as changing professions, moving jobs, and even resigning. Racial discrimination as a risk factor for burnout needs further study, and that there are few policies and practices that adequately address discrimination experiences. So also here is sort of a chart of the results from the Maslow Burnout Inventory for the general population. And if you note here, personal achievement is one of the highest of the risk factors identified. That study was very, very important because any approach that we take to provider wellness, it has to be informed by the experiences in our community. And so I am the administrator for the Primary Care Training and Enhancement Project. And what we're doing here, we were funded because even though we emerged from the ashes of the Watts Rebellion, still today we are experiencing healthcare professional shortages. And we also in South LA are experiencing a mental health crisis and epidemic as well as homelessness. And so it's important for us to provide, with the resources that we have, to provide as many people as with care. And so this particular project, we're integrating behavioral health and substance use, culturally appropriate substance use, into our training. And so for curriculum enhancement, we are training 89 clinical educators to infuse mental health, culturally appropriate substance use, and provider wellness into the curriculum, family medicine and psychiatry. Clinical care enhancement, we are infusing best practice material to advance the level of integration at our clinical sites where our PAs and our residents train. And then finally, provider wellness. We're leveraging the activities for this grant to develop a university-wide wellness service using evidence-based resources to address clinical burnout and promote overall wellness. So this is a snapshot of our workflow. So we have a wellness team that meets monthly, comprised of human resources as well as student affairs. Together, we will be implementing a comprehensive wellness assessment that will be deployed in the summer and the fall. And in this diagram, these are the instruments that we're going to use. The Maslow Burnout Inventory, as well as the American College Health Association Survey for faculty and staff. We're also looking at the scope of wellness through the 8 dimensions of wellness. And then we'll use qualitative focus groups to get more experience to take a deeper dive into what our pilot study found, which is 100% of our residents have faced some type of discrimination. So from that, it will inform individual as well as team profiles so that we can customize our wellness programming to be culturally appropriate. So some of the activities that we are currently implementing now are protected time and space. We have to build in protected time and space with no agenda other than our teams supporting each other and talking about what really matters to them. We also have time for individual and group reflections. And then we produced a mental health support guide during the COVID-19 crisis so that our residents, our trainees, and our faculty can put their hands on immediate resources. One of the things that sociologists have been studying is the mental danger, the mental health danger associated with the COVID-19 pandemic. And so we thought, that we need resources that we can get our hands on like now. Also self-care skill building apps. ACGME has a wonderful app called Aware. We definitely have recommended that, and it's excellent to use in concurrence with the mental health resources that we are providing. And then we also have psychologists that are doing workshops to manage the stress and anxiety of the COVID-19 pandemic. And then human resources blast out campus-wide something called Wellness Wednesdays. And there is an opportunity to promote well-being and different skill sets that are required to prevent burnout. And then finally, we repeat this assessment annually because our goal is to continuously build. You know, as Dr. Charles R. Drew taught us, we want to flourish, and flourishing requires iterations. And so that's why you see this diagram here. Finally, this is sort of a quick fix to what I consider a house to be burning. And so one of the things, here are listed some key strategies to kind of mitigate burnout. And so the first one is a physician listening campaign. We make sure that, you know, we got to hear, you know, what our providers are talking about. The second one is ask for feedback, and then recognize that feedback and fix the things that you can do in the short term. And so that's another strategy that we're also using within our wellness aim. And then decision making, you know, making sure that our providers and residents are involved in decisions that are made about their practice. And then finally, breaking the silence. Emotional support is critical during this time. And, you know, oftentimes we think of emotional support for patients, but our providers and our healthcare workers require it too. And so we are breaking the silence. And then finally, all of this has informed our approach to build a comprehensive wellness program that includes support services and evidence-based strategies for our faculty and our training. As Dr. Ricketts pointed out, there's excellent research about, you know, student burnout, physician and student burnout, and, you know, how it's an occupational hazard. It's a lot of wonderful research, and we incorporate that in what we do. But more community-based scholarship is needed, you know, because race, you know, is a stress within itself, coupled with all the other barriers, you know, that we've had to flourish through. So we need more, you know, hands on the ground. And then finally, prevention measures such as positive psychology that promote wellness and well-being are promising, and we're exploring those right now. We have a few professors in our college that are looking at the multi-dimension metrics of flourishing. And so, you know, we definitely highlight that in our programming. And so finally, I wanted to give you all some resources that I believe can help. The first one is taking care of the physician, you know, self-care. This was published in the New York Times, and I believe that could be value added. Also, doctors are human too. Humanizing the profession is something that's important as well. And then finally, why do doctors commit suicide? That's something else that's published in the New York Times. You know, we know that 400 physicians, you know, commit suicide annually, and that's disproportionate with the general population. And so we want you to have some support around that. And then the Hippocratic Oath has changed, and it includes provider wellness, so that's also documented here. And then finally, Happy MD, which is a YouTube series that provides coaching and you know, around burnout and wellness. So that concludes my presentation for today, and I just want to thank everyone, especially Cherie Holland, for inviting us to speak.
This is Carl Yonder, and I just want to, before we get to the question and answer session, we're going to pop up some poll questions. We're going to ask everyone to take an opportunity to complete. But I also wanted to highlight that we are having a clinical leaders peer-to-peer forum, leading together in uncertain times with Dr. Padilla and some from the field, and we just wanted to let you know that that's going to take place on June 25th from 2 to 3 p.m. So if you would like to participate, we encourage you to register in order to participate. The link is here, and you can get the link if you download the files, which include this slide as well as all the other presentations. While we get the questions from you all, we're going to have the poll question up. We're going to have 4 poll questions up here, so if you get a chance, please go ahead and complete the poll questions and answer the questions you have here. Thank you. Hold tight for question and answer.
So this is Lieutenant Sheree Holland. I'm from BHW Medical Training and Geriatrics Branch as a project officer. There was a question in the beginning. If you do have questions, please put them in the chat pod. This question came from PC. Are there any support group Zoom meetings or calls for frontline COVID providers to join?
Yeah, this is Kevin Hatcher from Charles R. Drew, and I just wanted to mention that our mental health expert that works on the project, she's a psychiatrist and has a Zoom session that she is offering for providers. And I'm happy to share that information. You can just contact me. The last slide has my contact information on it.
Okay. Thank you, Mr. Hatcher. And also, I was reading through comments that Dr. Mitchell Bierman had mentioned that the AGPA, which is the American Group Psychotherapy Association, also does pro bono groups for frontline. So that was a good suggestion. There was a lot of suggestions within the chat regarding a DoD provider resilience app. And again, really good dialogue during the chat pod. So if you have questions, please continue to put them in there. Thank you. Okay, I do see another question in the chat pod from Andrew Smith. How do we leverage public interest in healthcare workers' well-being during COVID to address advocacy for healthcare system changes that will improve our well-being? For example, moving away from fee-for-service. Dr. Ricketts or Mr. Hatcher or Dr. Barkley?
This is Dr. Ricketts. I mean, this is one of those things that there's a lot of emotion that is put into this issue of healthcare workers and how they're under threat, and they've not necessarily been treated absolutely perfectly by the organizations that they employ them. So that there is something of a public outcry for protection, and I would say that the organizational representatives of healthcare workers are trying to cope with this, but it's a catch-up kind of thing now as we discover what the real problems and impacts are. So at the moment, I believe we need to have, let's say, an open mind about the problems and understanding and letting people express themselves. Right now, they're having to express themselves primarily through open media, but I know that I'm not a practitioner, but I think that those practice groups are really gearing up for this sort of thing, and the states are trying their best on this, but it's a situation that we've not faced before, and trying to make everybody's voice heard is very difficult.
Thank you, Dr. Ricketts, for that. Another question came through. Do you have any research regarding burnout among mental health professionals that you can share? This comes from Morgan Watson.
Well, again, I'd comment that almost every field has had a focused work in this. I think we could probably identify fairly quickly a meta-analysis or a meta study, as it were, of issues. Burnout among mental health workers is real, and likely was one of the first fields in which it emerged under the rubric of burnout. Christina Maslick being a psychologist. So we're going to find almost everywhere that there is rather substantial work done in this field. But I think someone can probably I think with the help of a health sciences librarian, or if you or I could help if you direct a specific question to me.
I just wanted to add that there's a lot of resources on the SAMHSA website that, address, specifically behavioral health workers. So I would definitely refer you to that site.
And thank you both. There's another question from Chad Johnson. With many factors contributing to provider burnout, are some factors more influential than others? And the second part of that question is, are there some that could be prioritized for prevention efforts?
Yeah, this is the problem that I think we face when we're talking about trying to think of burnout as a unitary concept among all professions in the healthcare world. There are things specific to individual professions and the realm of disease and dysfunction which they face that create different dynamics. So it probably is that the generalized discussion that we heard earlier about supporting people, listening to people, those things that people value in general are an important component of reduction of burnout. Is someone listening to me, and does someone recognize this, is an important thing in general. So again, there is a necessity to focus research to specific professions and programs and work venues. But there's also an understanding that this is a common human element, that really burnout is something that all people will probably deal with in their lives, no matter what. And there are general issues that de-stress them, but specific to the healthcare professional, there are specific and focused things that have to be done because of the intensity of their work and because of the pressure of expectations on what they are supposed to produce. So a lot of work has been done focusing on healthcare professionals because of the stress. But the one thing that I go back to is the military also spent a lot of time dealing with this on folks whose job it is to basically kill other people. And not saying that you can, transfer one thing to the other, but it is a situation where you are trying to cope with people under intense stress, or not cope or help people who are under intense stress, and to reduce that stress and improve their ability to both survive and thrive. It's difficult, again, to find generalizations that work everywhere all the time, but there are general guidance that people provide. And I think in the healthcare professionals, the guidance of the national academies and their work is really where I would go to as a first step.
Thank you, Dr. Ricketts and Mr. Hatcher. There's another question. Do you find that providers in a specific specialty have a greater challenge in citing discriminatory practices? He states, I ask because there are very small networks and they may be fearful of retribution. I've heard of this being a huge issue among providers of color and women. Any thoughts?
I would refer you to a psychologist who is doing a lot of work on intersectionality and marginalized populations. Her name is Dr. Adina Winfield, and she's out of the University of Washington in St. Louis, and just recently published an article on some of the dangers associated with this in the Harvard Review. So I would definitely look her up and some of the work that she's doing around intersectionality and marginal populations.
Okay, thank you, Mr. Hatcher. There's another question from Menzo. What are some strategies that someone in management can utilize to influence upper management to take this issue seriously?
Well, again, that's the thing in organizations is to emphasize the fact that it is reducing the value of the product that's making organizations function inefficiently, and that there are consequences for the organization as well as the individual. Those are bottom line consequences as well as quality and acceptability consequences. So I hold that out as in my discussion is perhaps a good thing in that it is going to provoke large-scale organizations to deal with this, and they already do in many ways. I think the head chief nurse, the director of nursing, the medical director of large-scale institutions. This is something they deal with all the time. Is basically how to keep their practitioners practicing at their highest level and not burning out, as it were. And the sooner that a large-scale organizations understand that their productivity is dependent upon the well-being of the individuals within it, then you might have some type of progress. Industrial organizations learn this and forget it constantly. It's a lesson that needs to be repeated over and over and over again. It's the people who count.
Okay, thank you, Dr. Ricketts. And also, I just want to make a comment about Dr. Barkley. She did put some comments in there regarding literature reporting discriminatory practices. So thank you, ma'am, for that. At this time, we are running out of time, so we can't take any more questions. I just want to say thank you to everyone who participated in this webinar today and kicking off our first Grand Rounds for 2020. And have a wonderful day and look out for our recording and the next week, and we will have the slides available for download still in the downloads pod and next week during that recording. Thank you. Have a wonderful day.
Thank you for your participation in today's conference. All participants may disconnect at this time. Speakers, please stand by. Excuse me, you're now in the post-conference. One moment, I'll provide you with the line count. Okay, today we had 246 participants on the line.